What I'll be doing is assessing both in a neutral position. Well, in a neutral position, we have to assess it in neutral because there could be type 1 and type 2 mechanics in the lumbar spine. And if we assess it in neutral and we find 3 segments doing the same thing, what kind of dysfunction are we probably looking at here? Type 1 or type 2?
Type 1.
And if we are doing our assessment in neutral, we come across only one segment that's asymmetrical. What are we likely dealing with there?
Type 2.
And is it a major or a minor?
Major.
Because it's found in, and it means that it's lost how much motion?
More than 50%.
Oh, guys are rock solid. Good. This is going to go quick. The only thing that's going to slow it down is my jibber jabber, so I got to stop that. So once we do our neutral assessment, and it's easiest and best that you learn how to do this assessment first in a prone position. The reason for that in a prone position, you have no muscle activity helping them come into extension or keeping them in neutral. So it's a great position for everyone in this class here to own this assessment because it's a powerful assessment tool. And the way that we do that is we have somebody come up here in the prone position. So come on up, somebody. Beautiful, thanks. And rest comfortably. Now. Not at all. And again, you want to be on the same side, close to your patient with your dominant eye. Remember, look at the clock. Close one eye, close the other eye. Whichever eye keeps the clock in that little aperture that you created with your hand is going to be your dominant eye. So mine is the right, so I'm going to have my right eye closest to the person. And what we can do here, just going to expose your little back a little bit. And I just did this with somebody yesterday, and it was great. I wish you guys were all here to really see the dysfunction that I was finding in the spine. So I got to find our landmarks. We need to find PSIS. Okay? And then we know that if we come a little bit medial and then a little superior, we'll be at the level of L5. But we can't really get on the transverse processes of L5 because those transverse processes are blocked by the ilium in the back. So for L5, we're going to be on the lamina. And all we're going to do after we find that location is get an idea of the symmetry by first sinking our thumbs down onto the level of the lamina for L5. And then once I sink down past the tissue level, I can give a tiny little spring on the right and a tiny little spring on the left just to make sure I'm right at the right level. And then assess for symmetry. And here we have symmetry at L5. So now I'm going to come to the next level, L4. I like going up with the spinous process. It's easy to feel. And then come out just past that longissimus onto the transverse process of L4. Check left and right. Okay. Come up to L3. Repeat the same thing. Check left and right. So far, we're looking pretty good. Come up to L2. Same thing. And then L3, L1, thanks. And we're looking good. All right? So I don't find any neutral dysfunctions. I don't find, any neutral asymmetry. So I can rule out my majors, and I could rule out a type 1 dysfunction. Okay. Now I'm going to prop you up into prone prop. Hands resting on your chin resting on your hands. So the Sphinx position. Going to repeat the same sequence. Find the PSIS, go medially up till I find the spinous process of L5. Come a tiny bit lateral, let your belly just hang to the table. There. Okay? And that's the reason why we like to have them propped up onto their hands. Because if they're not, they're creating an extension moment of their long extensors to keep in that position, and that can throw your thumbs off. Okay. So L5, looking good. Come up to the spinous process of L4, out to the transverse process, looking a little deep on this side. So if she's in extension and I see asymmetry, where the left side is closing and the right side seems not to be closing because it's deeper, what am I thinking in terms of a dysfunction if I just stopped at looking at L4? FRS to which side?
Right.
Why
To the left side.
left?
Opposite.
Because I agree with the left.
Because the right side's open. It's not closing.
And the right facet is not closing, therefore it's stuck where?
Open.
And if it's stuck open in extension, it's going to look like this in your assessment. It's not extending, so it's not getting symmetric with the other transverse process. So it's stuck open, and it's rotated, the vertebral body is rotated which direction? So we name it based on vertebral body rotation. Not the side that's not closing. Remember that. Chad?
Oh, well, we were always remembering before, like, I understand that theory, but to help some people is always to say the side of prominence is the side of where the dysfunction is, like, as far as ERS or FRS. So if it's prominent on the left, you're saying it's not, closing on the right, but it's prominent on the left. Just remember that if it's prominent on the left, then it's FRS left.
Because it's rotated left.
Right.
I mean, if that helps you to understand that, that's fine. Use what you need to help you, but always reinforce it. That ask, what in extension do the facets have to do? They have to do what? They have to close. So if they're not closing, or if one is not closing, it has to be open. And if it's stuck open, it could only be rotated one direction. Okay?
But just remember your physical assessment, you're simply finding a prominence on one side, and that's the side is rotating.
Yep. That's exactly what Chad was saying.
We're beating into a dead horse, but just keep it really simple.
Okay.
Cross the-
So L4, I feel that my right thumb can go deeper. And that's an indication that that facet joint is not coming back, because on the transverse process it should be level with the left side. Okay. I'll come up to L3, and she's symmetric again. So we've confirmed that it's only a type which lesion? Type 2, single segment. Come up to L2, symmetry, and 1, symmetry. All right? So we did neutral and flexion, neutral and extension. We found the flexion lesion, and we already diagnosed it positionally as FRS to the left. What we now need to do is check her in a flexed position, and we can do that certainly in one way that's shown in the book, and I'll also mention to you a couple different ways. The way that's shown in the book is seated with the patient bending forward. And obviously, when they're in forward flexion, what are all the facet joints supposed to be doing? Opening. And if we find one segment in which it's not, it's stuck which way? Stuck shut, which means what kind of lesion do we have? An ERS. And then we have to determine, is it left or right? Of course, it's going to be the side that stays prominent. You could, and I'm going to demonstrate that for you in a second, have the person come up on all fours and just sit back on their heels. Check flexion this way. Okay. That's another way to check your flexion motion. You can just have them sit back on heels, just not shown in the book. Okay. And then you can sit and face the front of the class, which you're doing this side. That way, sorry. Yeah, I want it to be clear, not facing the class. And remember how I showed you before that if she flexes, we check flexion. She can also come up into extension. We can check extension in the same sort of dynamic method. But I really recommend that you stick with your static palpation at least until you get more comfortable with it. And then you can work it going into the dynamic mode of, okay, flex, neutral, extend, come back to the next level, flex, neutral, extend. You can see that that moves along a little quicker. But right now, go with the static position.
Well, it moves quicker if you can get the patient to do these.
Yes, and you feel comfortable. The disadvantage that you have here, though, is they might use their lumbar back muscles, and then that throws you off. That's why starting static is the best thing to do. So, to do that, you just have to have your feet flat. hands between your knees, and then just go forward into flexion. So I can again check L5 for symmetry. I want to look down and over. Check L4, and that was problematic. But you know what inflection it levels out, so that helps to confirm the FRS. Because it corrects fully in flexion, it worsens with extension. Just like an ERS would fully correct in extension and worsen in flexion. Okay. Come up, L3, L2, and L1. And then you've done all your static positional assessments for the lumbar spine. Why don't you guys take about 10 minutes to do that, and then we're going to start treating.